Good morning. It's a real privilege to be with you this morning. I think you'll find a lot of themes in the case I'm going to present are similar to the last series, and so I think it will be a wonderful opportunity to continue thinking about the issues that were raised, and I hope that we'll have a lot of time for discussion because I very much value your input in this as well. To begin, I do want to thank two individuals who helped me think about this case as well as prepare the abstract. Daniel Joyce is a medical student at the Mayo Clinic who has encountered some cases with dealing with the Amish and developed an interest in this interesting microculture that we, at least at the Mayo Clinic, frequently interact with. Furthermore, Dr. Chris Cholera just completed his neonatology fellowship at Mayo Clinic. He's now at Harvard doing a fellowship in palliative care. Dr. Cholera has some formal training in ethics at the University of Minnesota and has been incredibly valuable to myself as I've thought through this case. So I just wanted to start with thanking those two individuals. And I have no disclosures for this talk. So just briefly, let me give you some background, which will kind of carry on the previous discussion from the last session into this session. The best interest standard operates as kind of our ethical criterion for state interference of parental decision-making. I'm going to propose, though, that microcultures such as the Amish challenge the standard. Their decision-making is determined by complex cultural, religious, social beliefs and practices that are really integral to their community. And so when families from these microcultures, from these traditions, request withdrawal of life-sustaining treatment for their children, physicians, healthcare workers are challenged to balance, on one hand, the best interest of the neonate against the broader justice-driven context of the community. So let's look at the case. The case involved a neonate born at 33 and 4/7 weeks to a 45-year-old G12 P9 female. The family was from an Amish farming community in southern Wisconsin. The mother began labor at home and was rushed to the hospital. However, her baby was actually born en route. And when the EMS finally arrived on the scene, they found the father giving the neonate mouth-to-mouth resuscitation. They quickly transported the baby to the local hospital where the infant was intubated and mechanically ventilated. Now, the physician at the particular county hospital attempted to pass a nasogastric tube, but was only able to pass it about 8 centimeters. Something was obstructing it. It wasn't going as far as she wanted. So at this time, the decision was made to transfer the infant by helicopter to Mayo Clinic's neonatal intensive care unit. The diagnosis of proximal esophageal atresia with a tracheoesophageal fistula was confirmed. As you can see here on this chest x-ray, the nasogastric tube is not down in that gastric bubble, but hanging out in the chest, stuck in the proximal pouch. This was, however, surgically corrected on day of life 3. However, the neonate failed several attempts at extubation postoperatively. Bronchoscopy revealed severe tracheomalacia. Given the severity of the airway collapse, the medical team recommended tracheostomy and mechanical ventilation for months to possibly years until the patient growth would really optimize surgical repair. Despite an intact neurological prognosis, the family requested extubation and comfort care. Now, the father's reasons to discontinue the life-sustaining treatment included his religious values, the limited financial and physical resources of the community, specifically for the home ventilation. Like most Amish, this family rejected state-based medical assistance to offset the projected long-term medical costs. What was interesting is that concurrently, our neonatal staff was caring for a premature neonate also with tracheomalacia secondary to TEF, who had experienced a very long cardiopulmonary arrest and resuscitation, resulting in really an unclear neurodevelopmental prognosis. Nonetheless, this middle-class family requested tracheostomy and mechanical ventilation, and the baby was discharged within 24 hours with nursing care covered by medical assistance. What's difficult about this case is that, on one hand, the American Academy of Pediatrics has argued that physicians, healthcare providers, should take into account the values and the systems of belief of patients and their families when they care for critically ill children. Conversely, the American Academy of Pediatrics has also declared that decisions of withdrawal of life-sustaining treatment should not consider financial interest of the parents or the limited resources of the family. But for the Amish, justice-based concerns of resource allocation are intertwined in the value-based framework of the family. For this reason, the American Academy of Pediatrics directive to consider families' values in end-of-life decision-making directly clashes with the obligation to discount any concern of financial means. Now, at the risk of oversimplification, yet constrained by time, let me briefly discuss the Amish. It's a conservative Protestant group founded in 1693 who fled religious persecution first to Pennsylvania in the early 18th century. Now, in 2010, it was estimated that there's about 250,000 Amish who live in the United States in 28 different states. And although there's obviously diversity of belief and practices, in general, the Amish advocate simple living and rejection of modern technology as an expression or a participation in what they would consider separation from the world. They definitely demonstrate an anti-individualistic orientation. They form very strong communities and believe in a very strong sense of social responsibility. They believe also in a very strong separation between church and state. And for this reason, they refuse both life and health insurance. The Amish will utilize health care services when a child's symptoms are severe enough and when the father of the home deems that it's appropriate. Continuation of health care is often a decision made by elders of the particular community. However, families of those children and their communities thus must have to pay for the medical expenses themselves. Thus, given the limited and finite resources available to these communities, they must consider finances. They must consider the broader justice-driven context of their community, of their existence. So this decision-making directly challenges our best interest standard, which operates for the large part as kind of our ethical criterion for deciding when the state ought to interfere in parental decision-making. So let's briefly talk about this best interest standard. Now, a mentor and colleague of mine at Mayo Clinic, Dr. John Tilbert, recently wrote a paper called Shared Decision-Making After McIntyre. In this paper, he makes the following observation. The Enlightenment emphasis, Tilbert writes, on individual rights has shifted the moral unit of analysis from persons as part of a moral community whose principal goal was a shared pursuit of the good life to persons as individual, rational, moral agents whose principal goal was the free pursuit of self-declared interests or preferences. So to review, I'll just put this up on the slide. We've shifted from the moral unit of analysis from persons as part of a moral community to persons as individual, rational, moral agents. And the goal of ethics or of life was a shared pursuit of the good life, and post-Enlightenment, Tilbert argues, is now a free pursuit of self-declared interests. Patients are thus idealized as self-interested consumers in the medical marketplace, seeking information from medical professionals so that they can determine for themselves what the best treatment for them is. Many people rightly have serious doubts, however, if even a seriously ill, autonomous adult has the ability to bargain and barter with a physician in this context. And I would argue that children pose an even more serious threat to viewing medicine strictly through the lens of market capitalism. The inequality between physician and patient is greatly magnified when your patient weighs 1.25 kilos. Therefore, not surprisingly to any of us, it is parents who are the ones who are empowered to make the health decisions for their children. However, this authority is not absolute. Dr. Foss reminded us that yesterday, and Dr. Lantos just nicely outlined how societal change occurred in thinking about children with Down syndrome. No longer did society believe that parents have an ownership over their children, which was a belief that's been held for thousands of years in the history of humanity. In other words, the state can and does and should intervene at times. And the best interest standard has kind of become this criterion, both in the judicial sense and the ethical sense, to use to determine when this interference is appropriate. Now, although it's frequently employed as the criterion for assessing whether intervention is appropriate, there's people who have some questions about whether this should be our criterion. Doug Diekema, obviously no stranger to this conference, argues that this standard, the best interest standard, is insufficient for guiding decision-making regarding children. He argues first that it's difficult to even define what the best interest of a child is in many cases. Second, multiple factors must be weighed, not just medical considerations. Third, Diekema argues it is not clear that the best interest of the child should be the sole consideration in decision-making. In other words, the interest of child must be balanced against the welfare of others. And finally, Diekema argues that the best interest standard is really inherently a question of values. Diekema argues that the threshold for intervention should not be the best interest standard, but rather he argues for some sort of harm principle. Does a parent's decision significantly increase the likelihood of serious harm as compared to other options? Now, for our purposes, I am interested in discussing two of Diekema's critiques, that being the child's interest versus the welfare of others, as well as the question of values. First, I agree that parents do and should balance the interest of their child against the welfare of others. Parents of multiple children are quite accustomed to this balancing act. And as Dr. Ross somewhat humorously reminded us yesterday, even dragging younger brother to sister's soccer practice does pose some sort of harm on younger brother, such as a vehicle accident. So when he objects that he'd be much safer staying home playing video games, we see where he's coming from. Nonetheless, this is obviously more problematic when we consider cases such as sibling bone marrow donation, as we did yesterday. Now, I also want to discuss that many of these cases regarding parental decision-making might use the language of best interest, while in fact they're making an assessment of which values should carry the most weight. John Lantos argues along similar lines when he writes, quote, "In most cases, controversies about children's interests reflect controversies about the interests of the involved adults and about the types of values those adults hold dear." McIntyre has emphasized that different traditions constitute and also mediate rival visions of both justice and reason. This is in contrast to the liberal presumption that there exists some shared, ahistorical, objective rationality which can be utilized to resolve conflicts between different competing, socially embedded traditions. This Cartesian challenge, as McIntyre calls it, that is the belief that we can utilize propositions that would be evident to any rational person without any reference to some tradition or authority, is, according to McIntyre, an illusion. For he writes, quote, there is no standing ground, no place for inquiry, no way to engage in the practices of advancing, evaluating, accepting, and rejecting reasoned argument apart from that which is provided by some particular tradition or other, unquote. So for the Amish, the debate lies in whether a justice-based ethical vision should trump our traditional standard. So this case is really framed against the dichotomy of two families' decisions, one for and one against the withdrawal of life-sustaining treatments, which is very much compelled by their starkly different social contexts. It asks whether ad hoc bedside determination of resource utilization is a valid component of decision-making when it is so innate to this microcultural's social structure. Thank you very much, and I look forward to discussing this case with you.
Any comments?
I'm from Cleveland, which also has a large Amish population nearby. And in my experience, resources aren't necessarily the limiting factor. I've seen communities pool together to pay exorbitant amounts for chemotherapy for children. And I'm wondering about the money in this issue. And I also am wondering, could possibly the lack of electricity in the home be more of a compelling factor to not want to have a trach and mechanical ventilation at home? Also pertaining to the money, I know that many children who are critically ill, including children who have parents with insurance, often are eligible for state Medicaid, state emergency Medicaid, especially in Wisconsin where I have worked. And I'm wondering, just because the parents don't pay taxes, is that really a limiting factor to keep the child from getting Medicaid?
Thank you for those comments. In this particular case, I think certainly the lack of electricity did play a role. Practically speaking, if you were to elect the mechanical ventilation with a surgical treatment down the road, the child would most likely have to be put in a nursing home facility. This family already had 8 other children, a significant burden for the mother to maybe help out with the care, etc. So obviously there's more than just costs. One thing I've noticed about the Amish is that each situation is viewed as different and unique, and I've seen times when they've decided to go ahead with very costly treatments, be it a renal transplant, for instance. And I've seen other times where the community has made the decision that for whatever reason, they don't have the resources to push ahead with proposed treatment plans. So I think it's definitely multifactorial, absolutely. We do offer medical assistance for these children. They qualify for it. However, for social, religious reasons, the majority of families will not accept that. I have seen, in very rare cases, a family accept it, and it was very much kind of hush-hush and kind of done behind the elders of the community, so to speak. So that was a very interesting circumstance. It's definitely not the majority that, at least in my experience, I've seen.
Ben?
Yeah, Ryan, I just have a practical question about that case. Maybe you said this, and I just was not paying attention for that moment, so that's possible. In the case that Aaron described, their last session, there was disagreement among the clinicians about whether to seek a court order or not. I wasn't clear in this case, was there a uniform consensus not to do this, or was there disagreement among the group about how to proceed?
Thanks for that question. The withdrawal of care in this particular case was not controversial to the staff. What made people uneasy, or to use the phrase of the conference, what kept them up at night, was the reasoning for the withdrawal of care. In other words, we postulated, what if a family in the exact same situation came to you and said, we recognize the harms, the morbidity, that multiple surgeries, that mechanical ventilation, that unclear neurodevelopmental prognosis bears on our child. We've weighed all of these considerations, and we feel that it's in the best interest of our child to withdraw care. We appreciate your help, and we'd like to elect palliative care. It seemed, at least to the staff discussing the case, that that reasoning is common and would be respected, at least in most cases. What kind of threw the curveball is that this wasn't a best interest argument. This wasn't a harm outweighing benefit argument. This was a more practical, we don't have electricity, and this costs a lot of money, and we have limited finances. And okay, we haven't heard that, so to speak. And so I think that's what caused people to pause. And so the question for us and as a group is, this different way of thinking about the case, this different tradition-mediated approach, that being a more distributive justice approach, is it just as valid as our other ways of thinking about this? Or is it not? Is there some threshold that we've crossed, and how do we determine what that threshold is? So it was actually the reasoning for the withdrawal which caused unease, not necessarily the withdrawal itself, which I think is very interesting. I think in general, clinicians feel somewhat unease when two families in identical situations make different choices, and then when the reasoning for that choice is so different from the norm, it causes us to pause.
Please.
Hi, I'm Jane Jankowski from upstate New York. We do also have Amish families seeking care at our tertiary care hospital. And you sort of just addressed what I was going to state, is that what we've seen in our NICU is sometimes we do have very parallel cases, one being a child from an Amish community, another child being from a mainstream community. And should they both elect the same course of action? In your scenario, they elected different courses of action. In our scenario, they both wanted the same thing. We have greater comfort honoring the wishes from the Amish community because we understand, or we think we understand, their tradition, the rationale. The discomfort comes from respecting that same preference from our mainstream family who has the electricity, who has the resource, who doesn't have cultural barrier to receiving input. Can we honor both of those? Or is the context simply so different that we cannot? And what do we do with that? And that was a source of tremendous distress in our hospital. If you could address your thoughts on that.
Yeah, I think that's fascinating because whatever the case might be, is it the parental argument? Do we have to weigh the merits of the parental argument? In other words, if a parent comes to you and says, I think the harm is so great that we should withdraw care, and the NICU staff scratches their head and say, no, this is routine, it's not that bad, the kid has a wonderful quality of life ahead of them, I don't understand. And then on the flip side, if someone legitimately says we don't have the resources, the ability to proceed with this, do you judge those different or the same? In other words, does the rationale, the argumentation for withdrawal of care, or even for proceeding with care, should that be weighed differently for different people in different contexts?
Ryan, I'd just like to push you a little bit on that because I think that's been part of the conversation the last 2 days, which is the reason. Is being a Jehovah's Witness or being Amish or being something that is other than the common Judeo-Christian ethos, is that a valid consideration? If you give the wrong reason, then you have a different response. So is that valid as part of the conversation? And that's where I get moral distress on that issue.
Absolutely. And I tried to, briefly bring in McIntyre because I think he's been helpful in thinking about this. Because on the one hand, we recognize that reason, how we think about the ethical life, is embedded, it has to be embedded in a social context. We're not independent, rational beings devoid of any influence throughout our life. And yet at some point, too, MacIntyre wants to avoid any relativism, right? That any particular belief is just as valid as every other belief, or on the flip side, perspectivism, that any belief is only valid for that particular community. And that's where the rub is. How do we decide that? Obviously, whether it's Descartes or Rawls or whomever, appealing to some universal moral law that any reasonable person can rationally access, has been, it has some serious challenges to that. So where do we draw the line, and how do we go about that? For MacIntyre, I think his solution to avoid relativism was two things. One, you can look within a particular tradition to see if there's internal conflicts. So maybe, be it for a particular tradition, maybe there's texts in the Jehovah's Witness tradition which contradict their refusal for transfusion or whatnot. That would be one place to start. And the second would be, can a particular tradition withstand objections from the outside? This just doesn't seem to measure up to reality. So obviously people disagree about whether MacIntyre's approach can address this, but at the same point, we're still left without really agreeing about some sort of universal standard by which to measure this. I think the state has erred on the side of life is better than death, and so we tend to draw that line. But in this case, that very much challenges that notion, because this little Amish neonate is now dead, and we respected the wish of those parents. So no clear answer here.
So I have one more question in relation to that. When our society, which I believe will happen, and I realize I'm in a different healthcare system than you are here in the States, but when our society or the government says we do not have money for this, that, and the other, when justice becomes the overriding principle, then it's okay? If you gave the reason that is now socially acceptable, does that make it ethically different?
And that, I think, dovetails beautifully with Dr. Lantos' recent comment about the transplant and his observation that it seems to be permissible to allow families not to do transplant for the simple reason that we just don't have enough kidneys. And so, again, does the ethical permissibility of it change whether, this year we do have enough kidneys and next year we don't, and therefore we need to consider more justice type of questions? And so it's a fascinating thought experiment.
Ben?
I'll just add to that. I think that in relationship to your question, Susan, and Ryan's response, also in relation to John's talk, I think that long-term mechanical ventilation is one of those interventions in which there's still shifting attitudes, or the attitudes have shifted less than even for some of the other conditions that John was describing. I think, at least here, there's definitely an impression, although there's a range of views, that long-term mechanical ventilation is not the sort of intervention that people are comfortable forcing on a family or removing a family from a home because the parents do not want that. Whether that will change over time, I think remains an open question, but even in contexts where there's no cognitive problems, in this case there was the impression that likely there would be some developmental delay, but there's congenital hypoventilation syndrome in which there is no or minimal cognitive problems at all. There have been reluctance to sort of force mechanical ventilation.
Any other comments? So maybe we'll come back to that one after Renee's presentation.
Hi, good morning. I am very grateful for the opportunity to get up here and talk a little bit about some of the things that challenge me as a neonatologist. And one of the comments I have about this conference in general is that I find it very interesting that most of the cases that seem to keep most of us up at night are about when parents refuse therapies that we think the child should have. And my personal lived experience is that I'm much more commonly in a situation where parents are requesting therapies that I am not at all sure are right for the child. So we can talk a little bit more about that. But my talk, I think, will touch on several of the issues that were raised both yesterday and this morning, and maybe put sort of a different lens on some of the questions we've already been considering. So I'd like to begin by highlighting this dilemma. Parental requests for neonatal resuscitation of extremely premature babies in settings of pretty much clinical equivalence may feel very different based on the family's social context. And as I unpack this a little bit, I would ask us to be thinking about these three things. What role should family context play in physician treatment recommendations? Should the neonatologist be directive in some contexts but not in others? And what advice should an ethics consultant give to a neonatologist who faces this situation? So I'm also going to present two cases that have important similarities as well as important contrasts. The first case is Mrs. Greene. Mrs. Greene is a 37-year-old woman who presents with premature labor at 23 weeks gestation. This is her fourth pregnancy. The 3 prior pregnancies have all resulted in spontaneous miscarriage. She's had very good prenatal care with this pregnancy, and there really have been no problems up until this afternoon when her water broke and she developed premature labor. As the attending neonatologist on call, I'm asked to go consult the family, and when I sit down with them, it's clear that they're very frightened as they hear me discuss what the possible outcomes are if their baby is born today or tomorrow or in the next even couple of weeks. It's clear to me that they still mourn the loss of their 3 children who they feel they never even got to see alive. And they see this pregnancy as their last hope for a child because of the age of Mrs. Greene as well as their prior experiences. They, as we talk about what the long-term outcomes might be for their baby, say, oh, we understand what it's like to raise a child with disabilities. We've been very much involved in helping with our niece who has pretty severe, it sounds like, cognitive impairments as well as hearing loss. And when I tell them that because the outcomes for their baby are predicted to be so poor that we have a few treatment options, one of them would be palliative care alone. Another one would be to attempt to resuscitate their baby in the delivery room, but then to withdraw care in the first hours or days of life if it looks like the infant is doing very poorly. They quite urgently ask me to do everything possible to keep their baby alive. 12 hours later, my pager goes off, and I'm again asked to come over to labor and delivery to do a consult for a woman who is also presenting with premature labor at 23 weeks gestation. She's much younger. She's 24 years old. This is her 6th pregnancy. All of her babies have been born prematurely. She's had no prenatal care with this pregnancy, which means that our dating is in fact based on our best guess today. The fetal weight is estimated to be 480 grams. And based on what the mother tells us, we estimate her to be at 23 weeks gestation. The obstetrician tells me, importantly, before I go into the room, that Miss Becker is refusing tocolysis. She refused to receive the medication that is really our only hope of prolonging the pregnancy. As I hear about the case and I'm preparing to go see Miss Becker and reading through her chart, I realize that I know her. I realize that I took care of 2 of her babies who were in our NICU within the past 3 years. I remember that she had, and I see she still has, a long-standing use of heroin, cocaine, and alcohol. I remember our attempts previously to try to get drug treatment for her, to try to get secure housing for her, to try to secure transportation so that she could come and visit her babies in the NICU. All of her children are in foster care. And I also remember that after the last delivery, actually when she came in premature labor that time, she did sign the form for a tubal ligation. But because of the mandated Medicaid waiting period for tubal ligation, which if anyone wants to discuss that, that's a whole nother ethics talk, she didn't come back. And so she never got her tubal ligation. So when I go in to speak with Ms. Becker, I begin by expressing that I'm sorry. I'm sorry that this labor is so much more premature than the others. Her other babies have all been sort of in the 32-week gestation. And she quite quickly tells me that she's in fact not sorry at all, that she is sick of being pregnant and she wants this baby to come out tonight. So, I try to express myself a little differently and say that, well, my concern is that at 23 weeks, the risks for your baby are so much greater than they were for your other pregnancies. And she says, oh, you guys are always giving me some scary story about what's going to happen to my babies, and they always turn out fine, and this baby's going to be fine too. So I pursue and try to talk about what sorts of things we might expect if, in fact, her baby is born tonight or tomorrow in the next couple of weeks. And I talk about how important it is to do whatever we can with whatever tools we have to try to prolong the pregnancy, including tocolysis. And she tells me, nope, he's coming out, and you guys will do whatever you do to take care of him. When I reach the part of the conversation where I say that because the baby's outcomes are predicted to be so poor, there are a couple of options, including the option of palliative care alone or the option of initial resuscitation with withdrawal in the first few hours or days of life if the baby is doing poorly. She very clearly demands that I do everything possible to keep her baby alive. So I have really struggled to manage my own feelings that despite the fact that the clinical details in these cases are pretty similar and the parent requests are exactly the same, that there's something wrong here, that there's something different here. And you know what was so striking to me about the second case was the fact that on the one hand, Ms. Becker refused tocolysis, refused to try to do something to stop the labor, and on the other hand, demanded that I do everything possible to intervene for her child. And I, stepping away from this conversation and facing going back to the NICU to tell everyone what had just happened, I just couldn't make sense of how these incongruent requests and choices could somehow reflect some underlying goals and values. And that experience was only heightened by the fact that 12 hours earlier I had met with the Greene family who, you know, they may have made a decision that I'm not sure I would have made for myself, but the way they made the decision seemed to really reflect underlying goals and values. And so I'm going to spend the rest of my talk thinking through this issue and focusing on these 3 questions. How do we advance discussions with families about the authenticity of their demands for therapies of questionable benefit? Should parent commitment to or capacity for parenting their child impact our resuscitation decisions? And should clinicians be more directive for some parents in settings of clinical equivalency? So to the first point, how do we advance discussions with parents when they request regarding the authenticity of their request for therapies of questionable benefits. So certainly the American Academy of Pediatrics, as well as other expert panels, suggest that the gold standard for decision-making regarding neonatal resuscitation, when an infant's chance for survival is quite low and the chance of severe morbidity is high, that we as clinicians should help parents make decisions that reflect their goals and values. So to me, this suggests that parents' decisions, in fact, should reflect their goals and values. The problem for me came in this case that on the face of it, respecting each parent's wishes meant that I was going to aggressively resuscitate both babies. But only for Mrs. Greene did I feel like her rationale for requesting that was authentic and reflected her values. And only for Mrs. Greene did I believe that she was going to be capable of raising a disabled child, or even capable of accompanying a sick child through a NICU course. So as I started to think about that, I realized that I really felt unable, or at least uncertain, in how to engage Ms. Becker, the second patient, in a more important discussion about why she was requesting what she was requesting. And so I started to wonder, how could we as clinicians do the work of assessing whether a patient's decisions truly reflect, whether parents' decisions truly reflect their goals and values? And importantly, is that possible in this setting, right? In the setting of sort of imminent premature labor? And should we challenge parent decisions that in fact do not appear to be based on genuine goals and values? Maybe one way of beginning to think about this is something that we've already talked about several times, right? It's sort of trying to explore the narratives for each person in the story. What's the context? What's the background? What are the reasons? Who are the stakeholders in these cases, in my experience of these cases this day, and what are their stories? Since I'm the neonatologist, it's the perspective of the neonatologist that I can most immediately and authentically articulate, so I'll start with that one. I certainly have been trained to defer to parent requests when the infant outcome is likely to be poor. I've taken care of enough 23-weekers for 6, 7, 8 months in the hospital to see that the course can be very rocky, and there can be a lot of what I perceive to be suffering that I can't always alleviate. At the same time, I've been doing this long enough to see a few babies born this early who I thought were going to die, and who survived to come back and visit us in the NICU with a quality of life that their parents found very valuable. When I met with the Greenes, my heart went out to them. They've lost 3 babies, they so want a baby, and I wanted to help them reach their goal. And the very honest truth is, I was angry at Miss Becker for what I perceived to be her active decisions that were harmful to her child, her demand for therapies, for interventions on my part that were well and above the interventions that she was refusing to do for the baby herself. And at the same time, 23 hours into my shift, I knew that most of my colleagues would find the path of least resistance would be to resuscitate both the babies and worry about the social context when we got to discharge planning. So what about Miss Greene's story? She has a loving relationship with her husband. They very much together genuinely want to have a family. Although there's no medical reason to do so, she Sadly, blames herself for the miscarriages. Like most fairly young parents, she doesn't have much life experience with serious illness in herself or others in her family. But she fully believes herself capable of dealing with any challenge that could face her child, and she really can't imagine wanting anything less than heroic measures to try to save this baby. How about for the second patient, Miss Becker? So Miss Becker grew up in and out of foster care, mostly in. She started using drugs and alcohol early in her life when she was 13. She was raped when she was 15, and that was her first pregnancy. Now, nearly 10 years later, she quite genuinely would like to parent her children, but she has very strong problems with addiction and has never really been able to stay sober long enough to do so. At various points in her life, she has tried to do what the social workers and the doctors want her to do, and in her perspective, she's lost custody of all of her children anyway. So she's pretty sure that no matter whether or not she does what the doctors want her to do today, she's not going to get custody of this baby. She did not want to get pregnant again. Remember, she'd asked for the tubal ligation, and when she found out she was pregnant this time, she considered termination, but she never had the money to do so. She really does not want to be pregnant any longer. It's very uncomfortable. She's hungry all the time. She doesn't have enough money to eat what she wants to eat. She's done. And, sitting with us tonight, she feels humiliated, she feels mistrustful, she certainly doesn't believe that the medical team is going to make decisions that are in her best interest or in her baby's best interest, so she sees it as her job to protect her baby the best way she can, and the way she can is to tell us to do everything we possibly can to keep him alive. Now, what if, for a moment, we think about the narrative for these babies? We know that for babies born at 23 weeks, that the chance that they will die despite resuscitation is about 3 out of 4. Less than 10% of them will survive with no or mild disability. Obviously, these are population numbers, but I don't have any reason necessarily to believe that either of these babies is going to do particularly better or worse than this. The very likely short-term experiences for each baby will be at least 4 months in a hospital, mechanical ventilation, central lines, infections, feeding complications. And the very likely long-term experience will be moderate disability. Now, their experience may be better. We know that if they grow up in an enriched social environment. We know it's going to be worse if they grow up in a deprived social environment. And in the case of Miss Becker's baby, one would expect that this baby is also going to enter foster care. The adoption rate for medically fragile children in foster care is less than 1 in 5, and it's even less if you happen to be an African American child. So there are a lot of other stakeholders we could talk about here, but for the sake of efficiency, I just want to touch a little bit on the community within which this hospital resides, that Ms. Becker comes from, and that Ms. Greene comes from. So this hospital enjoys a rather complicated relationship with the community. On the one hand, it's seen as a miracle hospital. Take your child there, they'll be cured. And on the other hand, people think that we're doing secret and unauthorized experiments on their children. All of this relationship is quite clearly seated within the community's strained black-white race relations, and it is undeniable that the city's health and social equalities are greatest among the black families. And there are some who feel in the community that interventions, medical care for the most vulnerable patients should be at even a higher standard because of the past and present inequalities. So when I have had a chance to sort of sit with these narratives for longer than you have had today, they do in fact help me to come to some greater understanding and peace about what's going on here. can better understand Ms. Becker's, on the one hand, decision to refuse tocolysis, and on the other hand, to ask me to do everything to save her child. Now, obtaining benefit from these narratives, of course, requires that I'm able to uncover those narratives, and I have some questions about what skills I personally need to enable me to uncover these narratives in a fruitful way, particularly in the context of a prenatal consult. But let's assume for the moment that I can, and that I do, and that I understand Ms. Becker a little bit better after going through this process. Even so, we are still left with this question about should parent commitment to or capacity for parenting impact our resuscitation decisions? So on the one hand, we could look at this question by asking, how do we approach families who demand that clinicians provide a level of care for their child that they themselves are unwilling to provide? The flip side of that question may be, does a parent's commitment to wanting to raise a severely disabled child have greater moral standing than that infant's arguably small chance of surviving to NICU discharge? So trying to wrap my head around this has really only led me to even more questions. So one would be, well, which social context and which decision would activate this additional evaluation by the clinical team about the parent's capacity for parenting, right? So the two decisions in this case could maybe be thought of as no resuscitation or resuscitation, right? For Ms. Greene, who seems to be making a decision out of a commitment to her child, a commitment to raising her child, maybe you would say that both decisions would be acceptable, right? Because they reflect her goals and values. Now, someone could, and perhaps Dr. Lantos would, argue with me about whether or not the option of no resuscitation of a 23-weeker is an acceptable option. Some of you may argue with me that the option of resuscitation of a 23-weeker is an acceptable option. Let's just say they're both acceptable at this point. The question is really, I have mostly been presenting my concerns about Ms. Becker's request for resuscitation of her baby, but when I start to think about it more, I realize that actually maybe I'm uncomfortable with both requests, because maybe if I'm worried about her commitment to this whole process, maybe neither decision would be okay. So if we accept that maybe parent commitment in this situation is relevant to decisions, the question, of course, will be, well, how would we assess that? I mean, what skills would I need in order to engage people in conversations about this? What standards would we use? What past medical history or social history would be relevant or not relevant? And do we only assess immediate commitment or capacity or future? So is it only Ms. Becker's capacity today, or is it if she gets in drug treatment in 6 months or in a year? What sorts of information would we count as reliable for this process? So if we pursued it further, right, if we took it further and said, well, we could in some way assess this. What if we did assess this and we determined that a parent's capacity or commitment here was poor, right? Let's take it the next step. What if we decide that a parent shouldn't be participating in this decision? What would we do then? What would be the next process? I think that clinician recommendations would come to the forefront, right? If we're engaging in a medical decision about an intervention that has questionable benefit for a child, and that decision typically heavily weights parents' goals and values, and we take parents' goals and values out of the picture, then physician recommendations seem more important. Well, what sort of process would it be for the medical team or for the hospital team or for some team outside of the family to be making this decision? Well, maybe one option would be that I would make the decision. I'm the doctor that has to go to the delivery room and resuscitate the baby. I'll make the decision based on my clinical and ethical judgment. Now, maybe you'll tell me that I have too many conflicts of interest here and I've been up for 23 hours and I shouldn't be making that decision. Well, maybe the clinical team should make the decision. Maybe everybody who's going to be involved in the resuscitation, the nurses and the respiratory therapists and the fellows and the residents, maybe we should all be a part of this decision. And maybe Maybe there should be some standard whereby if anybody in the group thinks that we should resuscitate, then we resuscitate. Because the only option that can't be undone here, right, is non-resuscitation. So maybe you'd set a minimum standard and say, if anyone in the group said we should resuscitate, then we'll resuscitate. Or maybe the clinical team is too close to the story and there are too many chances for poor judgment and bias, et cetera. Maybe there would be some sort of committee who was charged with making these decisions, that was trained for and charged with making decisions. Who would be a part of the committee? Ethics consultants, parent advisors, other clinicians, and they would decide more in the way as with organ transplant committees. So if we had this process of putting forth recommendations, right, where we would take the responsibility of saying this is the right thing to do, obviously a really important piece of this is who is the child's advocate and how does that advocate make decisions. So whether the child advocate is the ethics consultant, whether the child's advocate is court appointed, the question is, how do we judge the outcomes from the child's point of view? Would we make a decision with the goal of maximizing the good outcome? And I would challenge you to say, well, what's a good outcome here? Is a good outcome a rapid death after birth with minimal pain and discomfort in the warm arms of someone? Is a good outcome survival with minimal disability and early adoption? Or would we, in this process, prioritize decision-making to avoid some worst possible outcome? And again, I would challenge you to, what is the worst possible outcome here? Would it be a complicated NICU course with multiple surgeries and infections and death before the baby left the NICU? Would the worst outcome be severe or profound disability and a life in foster care? I'm not sure. All of this sort of brings me back to the beginning. Should we be more directive for some parents? We have two families, we have two clinical scenarios. They're very similar. The families are asking the same thing of us, but the contexts seem really different, and what should we do? So I'm very hopeful that you will have some questions and thoughts and generate some discussion around this. I do want to take a moment and say that Dr. Ben Wilfon has been working with me over the past, 3/4 of a year or so as part of my K-23, and has really helped me go from a point of just feeling like my head was going to blow up from thinking about these things to being at least able to articulate a few things and generate some more questions. So thank you very much, and I welcome questions or thoughts.
Please.
Hi. I'm on. Thank you very much. This was really stimulating. I have some questions for you, Dr. Boss. I think it's a very slippery slope when, and I don't believe that we are in the position to judge. And you say that you're hoping that the answer to the question, to the abandonment question, would basically inform what the standard should be, and there's something that just doesn't feel right about that. I believe that each fetus has the same rights. What I think, if I was the ethicist in this case, what I may ask you, and I so appreciate and applaud your the sharing of your feelings about this, and Mrs. Becker is someone who, it sounds like she was a morally objectionable character. And so what I might ask you, it's not really how we think about it, but it's how you feel about it. What would it take for you to move from a place of anger to a place of somewhere else, where you might be able to recognize the extreme vulnerability of this 24-year-old mother who grew up in foster care, and her obviously is not as fully invested in the outcome because she doesn't believe she's going to even be, parenting this baby. It's certainly unfair, but I think that maybe if you yourself are able to move to a different place of acceptance, we may feel less likely to judge it.
Yeah, and I think, I think that's what I guess I'm trying to move towards with the sort of this narrative approach, right? This approach of not just seeing her actions and behaviors and attitudes tonight, or even the past couple times, because I have more than one experience with her. And certainly it does, it quite genuinely does help me understand why she would, it helps me understand why she would ask me to resuscitate her child. I'm not sure I'm there with helping me understand why she won't accept 48 hours of a medication that try to maximize her child's chances. So I'm still a little pissed off about that, to be honest with you. But
She may have a personality disorder.
Yeah,
might be
totally fair.
narcissistic or
that's
things that
totally
we
fair.
can't-
There may be other motivations. I'm just being genuine with you about, trying to wrap my head around this. So certainly hearing more about her story helps me, right? And I guess that's my point, and that's what we've discussed in many ways, throughout this day and a half, is hearing the story is really important. But I'm not sure that fully helps me deal with the issue of her not being invested here, and whether or not it's fair for me to let her dictate this decision that I'm not sure is in the baby's best interest either. And maybe because I'm not sure, either decision would be okay. You can push me on that. But understanding her and having sympathy and empathy and getting it a little bit more doesn't help me with that hurdle.
Please.
Hi, I'm Dahlia Feltman. I'm a neonatologist in Evanston, Illinois, and I really appreciate both of your talks today. I think you guys have touched on things that sometimes we don't even want to talk about. Our discomfort with making decisions based on limited resources or financial considerations. Renee, you talked about, I think you've talked about how we don't always relate to the patients and therefore maybe aren't as comfortable with their decisions, and we have some moral distress on what the right decision even is. I see these two cases as quite different than two of the cases that we talked about yesterday. I would contrast these cases with the ones from yesterday, the Jehovah's Witness refusing a blood transfusion that is clearly life-saving. Actually, the other case was earlier this morning, felt like yesterday, where the dialysis patient, where it looks like the benefits do pretty clearly outweigh the risks. In both of your cases, I would say that the problem that we're having isn't the decision, but the process by which the parents got to the decision. And in that case, I guess I would argue for the 23-weeker, if both options of resuscitation and non-resuscitation are equally ethically acceptable, and in Ryan's, is prolonged mechanical ventilation truly something that is morally obligatory? Probably not, I would think. Then do we need to kind of step back and say, even if you gave me the decision, like Renee, you extrapolated to, let's say there's perinatal foster care. We know this kid's destined for foster care, but obviously isn't going to be in it when they're born in the delivery room yet. Our values are going to play into making the decision, even if I get to make the decision for the baby. So do we have to kind of step away and say, they're both equally acceptable, I don't really understand the path that the person took to get there, but we need to maybe just leave it alone. I don't know what your thoughts on that are.
I'm just not satisfied with that. I find.
But then what is, maybe then you have some bias towards what the decision should be.
Mm-hmm.
Do you think that might be it?
That's fair, and I think I do. I think that there are some treatments that I provide that I'm not convinced I should provide, and so I struggle with that. And the fact is, I did resuscitate both of these babies, and they did both survive. And but I don't know. I think again, much of what we've talked about here today is a situation, and yesterday and today are situations where parents are rejecting therapies that we think are in their child's best interest. And when families embark on decisions that obligate a child to a very, very questionable benefit and seemingly thoughtless decisions, I don't know. I'm just not sure it's right to go along with that just because I would accept it from someone else. I don't know. I can't quite wrap my head around it.
I agree, it's very difficult. Thank you.
Yeah.
Please.
Thank you for that presentation. I really appreciated how honest you were, and having done my NICU training in DC, I've taken care of a ton of Mrs. Greenes and Mrs. Beckers, and so I could really see myself reflected in your narrative. I guess my question is about what I think is an underlying issue in both cases, which is who bears moral responsibility for a, quote, bad outcome, however you define that. And it seems like in neonatology we might have a kind of heightened sense of our moral responsibility for the serious or negative outcomes for our patients. And when you talk about the case of Miss Greene, I think part of what feels more comfortable about that is that both the family and the physician share responsibility for the outcome. We're in this together, and we both bear the burdens of the decision. In the case of Miss Becker, I think for myself, when I've been in that situation, I really felt like the burden of this decision is on me because this family member is not meeting me in the middle. They're not putting into this decision, and so I own the responsibility of the bad outcome. And I guess I wonder if it's fair for us as neonatologists to do that to ourselves. When a kid comes into the PICU after a near drowning and leaves with significant deficits, you don't often find the PICU doctors saying, we did that, we own that, that was a bad outcome and it's our fault. And you can point to examples in a lot of different fields in pediatrics, but pediatric doctors oncologists who take care of kids with pediatric brain tumors don't generally beat themselves up when those kids survive with deficits. And so my question to you is it fair for neonatologists to own so much of the responsibility for the quote-unquote bad outcomes of our patients?
I'm not sure I have an answer to that, but what I would say is that the process that I went through and sort of thinking through this talk, and in particular thinking through the issue about, well, so let's say that we took the parent out of the picture because we deemed them not able to participate, and so then we tried to figure out, well, which group of us could make this decision, right? And if we were going to make the decision, what would we base it on? Would we base it on the best outcome or the worst outcome? And as I generated what those best outcomes and worst outcomes were, and I really was like, oh, this is just so hard. And then I thought, well, I mean, that's the choice I'm asking every parent in this situation to be responsible about, right? And I really felt that in a way I hadn't before sort of going through this process myself and really articulating what it was that I was feeling when I took the parent out of the picture and really feeling like yeah, this was me. So now I was making the decision, and maybe part of my discomfort in the second case is that I don't have anyone to share that burden with. That's fair.
Renee and Ryan, my name is Paul Mann. I'm a neonatologist here, and thank you for these thoughtful cases. Renee, this is for you. In particular, you quote in this case 25% survival for infants at 23 weeks, but in recent papers of the Neonatal Research Network, you see individual centers have variability from 10% survival to 60% survival, and the Japanese experience at 23 weeks is very much in line with the 60% to 70% survival. And so, I wonder how much of the moral distress that individual centers feel in these cases reflect their own survival, and what's the obligation of providers to show transparency about their own individual centers' survival and neurodevelopmental outcome in these cases.
Yeah, so I guess that makes me think of two things. So one is, you're absolutely right, there's significant variability. What is also true is that there is not variability in neurodevelopmental outcome. So it is true that more babies survive in different centers, but still 50, 60, 70, 80% of those children have at least moderate disability. So survival and survival with quality of life are not the same thing. You're probably aware of that, a number of recommendations that when we present to families sort of outcome data in prenatal consultation, that you present both local and sort of national data. And that is our practice at our institution. We have little graphs that we present with these are the outcomes. I think underlying what you're talking is about is sort of, this issue of the self-fulfilling prophecy in neonatology, right? So, 90% or the 75% of 23-weekers die, well, how many of them get sort of the full court press? Of the babies that get full court press, how many die? It's less, right? And so some of the numbers are messed up by the fact that we don't resuscitate everyone and we don't do full court press, and that's why those NICHD data are really a lot of fancy math, right? They're not real data. So your point is well taken, and the Japanese just, they push our issue with hypoplastic left heart too, right? I mean, there are definitely cultural, regional issues. How much transparency is needed? If I know that my peer facility in Washington, D.C. has better outcomes at 23 weeks, am I obligated to tell this mother, if you really want this, you should really be transported to D.C.? Mark Mercurio wrote some stuff about that, about trisomy 21 and ECMO, and how transparent do we have to be that there are other places that have better numbers. I don't have an answer for that either.
Yes.
Hi, Kate O'Donnell from McMaster University. It seems to me that this woman, Ms. Becker, has essentially given up her right to have any real say in this decision. A comment was made that she's a young mother, but to me, that doesn't seem right. She seems like a young woman who's had multiple pregnancies. To me, the term mother would infer a sense that she actually would put her needs second to the needs of this child. She doesn't really seem invested in what should really happen to this child, as you said. I mean, the fact that she wants this child out at 23 weeks just because she's uncomfortable, and she has no real interest in raising this child. But something's, maybe you can help clarify this. Maybe we're missing something and why she cares all of a sudden when you talk to her about the complications afterwards. She wants you to do everything, but she's not willing, as you said, to take the medication to have this pregnancy just for a little while longer. Could you talk about that a bit?
I can try, although...
or maybe you don't know either. Something just seems...
I certainly don't feel like I ever fully understood why, she disappeared after having this baby again, and the baby went into CPS custody quite quickly. So much of what I present about her narrative is partly what I think her narrative is, but I haven't had a lot of chance to talk about that. But my true sense is that this had a lot to do with a trust of us and belief that we were going to make a better decision, and her desire to do to do this thing that seemed to be something to protect her baby, and that she didn't really believe that, you know, the medicines were going to do anything anyway. So, or she also didn't really buy that the baby was going to be as sick as I predicted, because apparently I had been wrong before. So, you know, she didn't trust me. She didn't trust us. She didn't trust me. I think that's the essence of that piece. But your point about, you know, what is a mother and what is a parent is some of what felt so icky about all of this.
Mm-hmm. I'm not a mother myself, but I've watched many who are sort of my age and older who would do almost anything in their power to protect their child, even if it meant giving up their own life. And this woman just doesn't want to be uncomfortable. That seems a little, you know.
Yeah. And you may be right that, you know, there are underlying, you know, psychological, psychiatric, other issues here. But that would be another thing, by the way, in the urgent prenatal consult that I rarely have time to settle in a way that makes me feel good about it.
Sure.
Well,
Thank you.
very much. I know I have a whole page of comments and questions, which I won't get to either. But I thank our very provocative presentations, a lot for us to think about. The presenters, very eloquently done. Thank you.
Thank you.